Hi, everybody. My name is Benjamin Leopold, and I'm going to be talking about affirming care and LGBTQ youth. So, my problem statement is LGBTQ youth are more likely to suffer from mental health disorders, including depression, compared to non LGBTQ youth or heteronormative youth. And there's also unique struggles that the population faces, and so kind of moving on from there developed my hypothesis that, given the unique struggles of this population, would affirmative behavioral therapy lead to a greater reduction of depressive symptoms compared to non-affirmative cognitive behavioral therapy treatment. And then that grew a little further into the research question that I have, which is among LGBTQ youth with depression, how does LGBTQ affirming treatment compared to non-affirming treatment impact depressive symptoms? So I wanted to look at if there's any sort of benefit from treating them kind of as you would any other patient and not placing more emphasis, or if there's a greater impact on positive outcomes from leaning into that and saying, hey, this is important to you, we're going to focus on it in treatment. For sampling design, I looked at LGBTQ youth with depression, keep it on youth between the ages of 10 and 25. That covers adolescents. We don't really want to go younger than that, up to young adults to age 25. And we're going to look with a probability sampling. And what that means is it's also stratified random sampling method. So that's going to involve dividing the population into subgroups and then take random samples from these subgroups. And so what I'm going to do is I'm going to divide it into, adolescents and young adults when I'm looking at the data. And the reason for doing that is just to make sure you're capturing the full age range. If you just do a purely random sampling, then you might end up with, all skewing toward the younger end or all skewing toward the higher end. And you want to make sure you get every age as much as you can, get a more representative sample for the general population. And I think this will help do that. For theoretical framework, the three main theories that really came to mind first when I was looking at this are the person-centered approach, systems model, and the person in environment approach. Now, the reason I first thought of these, particularly with this community, is because we want to look at, just going down the list. For person-centered, we want to look at the individual. We want to look at the person in front of us and understand their unique challenges. And that really ties in well with person and environment because the entire idea is that you want to look at them in the context of their life and understand that they are not in isolation. They are not simply this individual who happens to identify as part of the LGBTQ community. They are a person who is part of a family, who goes to school, who has hobbies, who has likes and dislikes. And all of that influences them. It plays a part in their depression. And we want to make sure that we're considering that. And so that's why you keep a person centered. You want to look at what is unique to them and also look at them in their environment. And I think combining those two will be really helpful. And as you can see, literature very much supports this. There's just one example on screen about how Philia et al. Really underscores the importance of that because those outside factors that we're not necessarily looking at beyond the LGBTQ community, if we ignore them, they're still impacting treatment outcomes, whether you look at them or not. So it's very important to consider that, and that's a big thing that's going to be guiding my framework here. And as well with the systems model, just another example from the literature that I found. These people are part of their family system, right? Their family is impacting them, and they are impacting their family. And the way that those interactions occur can play a big part in um, increasing resistance to seeking treatment. It can make them, experience more depressive symptoms. It's going to impact every facet of their life in how they fit into this role. And that's going to be a really big part of what's playing into their pathology. We want to make sure that we're looking at that um, in the therapeutic approach for this study. For methodology, it's going to be focused on quantitative. The reason for this is just get hard numbers; they're easier to track. And I thought that particularly with looking at one treatment group who's receiving the affirming care, and then the one control group who's not, it's much simpler not to look at what the clients are thinking is working and get hard numbers on what they are reporting as far as the depressive symptoms go. And to do that, we're going to use the Beck Depression Index and the Patient Health Questionnaire, the PHQ-9. Both of those are going to provide hard numbers on how the clients are feeling. They'll give us, hard rating, and then we'll be able to track that a little more comprehensively that way. As far as procedures, we want to look at the target population. So we're going to keep it around my home area, keep it around Buffalo, New York, the greater area around the city. And we want to make sure that participants fall into that age range, 10 to 25, identify as a member of the LGBTQ community, and they are also proficient in English and are not currently enrolled or in therapy or receiving any kind of counseling. The reason for that is we want to make sure that we're removing those variables. Obviously, if patients are receiving extra care outside of what we're providing, that would skew data, and given that it's an untested variable, it would not be good for the study. So we want to avoid that. And we also want to make sure that we are, when we're recruiting, we want to make sure that we are remaining professional. So we want to contact school administrators, see if we were able to put up flyers. Same thing with online. We want to make sure that contacting admin for LGBTQ Facebook groups, for example, sure it's appropriate to post there, and keeping in contact with families and whatnot. Make sure everything is above board as far as data collection goes. And there's going to be pre and post assessments included in this methodology because we want to make sure we're getting a baseline at the very beginning of treatment before the intervention has begun, so we understand where our sampling is at the moment, when they first begin, and then at the end with a post assessment. That way we can look at the trajectory of treatment and really track if there has been a decrease, an increase, or kind of a stabilization of depressive symptoms as it moves across the treatment course. And the intervention will last 10 weeks with one session per week. That kind of gives time for kind of behavioral therapy to work, and it also is hopefully a short enough time that people are willing to sign up for it. A couple months sounds a lot better than half a year or so. For the literature review, some trends I noticed I just want to highlight because I don't want to go over all 12 sources, but some trends I noticed are that affirmative care really does lead to more positive outcomes, and that really connects with the impact of the therapeutic relationship on treatment, specifically the impact that cultural humility has on the therapeutic relationship, which plays into affirming care because in the literature that I found, there are trends that suggest that not only is affirmative care a very big contributor to positive outcomes, so too is cultural humility. clients found that if they experienced culture humility coming from the side of their counselor, that strengthened the therapeutic relationship, helped lead to more positive outcomes. And there's also some implications of training here. The implications being, is the training working and is it not? So, as far as cultural humility, is there a correlation, given that there is, with positive outcomes and cultural humility? Do we need to train more clients in it? Do we need to change what the training is? Same with affirming care. Are we needing to make sure that it's not necessarily what treatment we're providing, but how we are providing it? And in what ways do we need to adapt with that? And especially given the higher rates of mental health symptoms that was touched on in nearly every article that I found about the subject, how crucial it is that we are taking this seriously and finding ways to really specialize care for this community. Some limitations working with the LGBTQ community are the stigma they face, diversity, and trauma. So those three all play together. Stigma, unfortunately, still near 2026. It's still permeating in society that there is kind of this idea of how they're this minority, they're not always viewed as equal, unfortunately, still. And we have to take that into account when people are maybe not wanting to identify as part of the community. Is that going to reduce the numbers that we're able to find? Or are people going to misrepresent themselves? Are they going to identify as bisexual, maybe because that's more accepted in their eyes than solely gay or solely lesbian? And then that's going to impact the diversity of the respondents that we get. Because if you're only receiving people identifying as bisexual, that's hard to understand if that's truly representative of the wider culture and the wider community. And in the same way, in a more traditional sense, if everyone identifies as a a Caucasian, for example, then that's not then a study would not be representative of people who are of ethnic or racial minorities in the country or in the wider world. And with trauma, you want to make sure that given the stigma that is faced, and there might be some people who have faced some trauma tied to their sexual identity. And maybe what that means is that not necessarily the treatment might not work for them, but it's just that this level of care is not what they need. So it's important to consider all of those things when you're working with this group in particular. Some implications for study are just that this can really impact how we look at treatment for specialized care for this group and for others. Do we need to expand affirmative care to look beyond sexual identity and perhaps racial and ethnic identities, and how that impacts treatment for those groups? And if we need to relook at maybe what we're doing and how we're doing it specifically. And that can benefit the field, and it can help us just grow our knowledge. And we want to make sure that we are providing the best care. We're not just providing adequate care for clients. We don't just want to see improvement. Of course, we do want to see improvement, but what we want to do is we want to make sure we're providing the best possible care for clients. And if we're studying the difference that affirmative versus non-affirmative can make, that is very widely applicable to every level of social work care and can increase making sure that it's not just positive outcomes, it's best possible outcomes for patients. And here are my references. Thank you for your time, and I hope you have a good rest of your day.